Doc- Okay. Dr. Newman is a geriatrician and basic scientist, an assistant professor at the Buck Institute for Research on Aging and in the Division of Geriatrics at UCSF. His research focuses on how metabolic molecules regulate aging mechanisms that contribute to Alzheimer's disease and delirium. His clinical work at San Francisco VA Hospital focuses on preventing delirium and disability in hospitalized older adults. We love having the Buck Institute at the Sunday Symposium. So John, take it away.
Thank you, and delighted to be back here. I'll get my slides set up here. And thank you everyone for joining yet another Zoom call. I was really hoping that we were going to do this in person, and a month ago we would have. It would have been great. And a month from now we may be able to again, but such is life in the pandemic. I'm glad still that you joined in. So thank you for that kind introduction. I am a geriatrician physician scientist at the Buck Institute, UCSF, and the San Francisco VA. And I spoke with many of you last year about some of the cutting edge science around the biology of aging and how it's translating into clinical trials to improve human health. But this time we're going to talk a little bit more with my physician hat on as a geriatrician, how to be your own geriatrician, which has never been more relevant than in the middle of a global pandemic. But we'll talk about what that means. Well, I guess first I'll echo some of the introduction. So I wear many hats. I run a basic science lab at the Buck Institute, mostly doing experiments with test tubes and mice around studying how metabolism and particularly ketone bodies interact with aging mechanisms. But I'm also a geriatrician at UCSF. My clinical work at UCSF is mostly at the San Francisco VA, where I work about 2 months out of the year, all in the hospital, taking care of hospitalized veterans, doing both general medicine, of course, with a geriatric focus, and geriatric consults specifically to help other doctors take care of our wonderful older veterans. And this talk is inspired by my experiences as a geriatrician interacting with both people and with the doctors who take care of them. How to think like a geriatrician. And we're going to start off just a little bit of introduction about what does that even mean? What is geriatrics? Who is geriatric? How do we think of ourselves as doctors? What makes us different from other doctors? Of course, many of you have probably heard about geriatrics, this medical specialty that focuses on older adults, which makes it a little bit different from other medical specialties. You know, the cardiologists have their hearts, the pulmonologists have their lungs, the rheumatologists have their joints. What do geriatricians actually do? Well, we think what makes us a little bit different is that because the people that we take care of are so complex, we focus on goals and we focus on treating the whole person. I'll talk a lot more about what that means as we go through the next 30 or 40 minutes. But by goals, I mean that it's medicine with a purpose. It's not doing things because we can do them or because we think it might help, but it's doing things to try to accomplish goals that are important to the person sitting in front of us. And so part of that, of course, is figuring out what those goals are and then personalizing in a precision medicine sort of way, as I like to say, how to target medical care for that person to meet their goals. And that requires treating the whole person. This is why geriatricians aren't just about the heart or the lungs or the brain or the kidneys or what have you. We have to understand how all of these things interact with each other because they do. And we need to make sure that when we're turning one screw or hitting one nail, that we're doing so in a way that helps the whole thing. And isn't going to cause more problems than it solves. So goals and treating the whole person are the themes that we're going to come back to over and over again. And what underlies that is the reality of complexity. Especially as we get older, everything gets a little more complicated. And this is very much true in thinking about medical problems in older adults. It's never just one thing. If there's a problem with someone getting short of breath or having balance problems or something like that. It's never just one thing. And we'll talk a lot about how we conceptualize approaches to that. And everything affects everything else. With the best of intentions, you can do something that winds up causing harm in a different way that you may not have anticipated. Or it may not be obvious why doing something is going to help something else. But everything interacts. So sometimes geriatricians, rather than calling ourselves doctors for older adults, we call ourselves complexivists, because the fundamental of our practice is working through this complexity in a science-based and useful way. So why should you try to think about or try to learn how a geriatrician thinks? That's our job, right? But this is the problem. There are very few geriatricians out there. There's only about 5,000 in the entire country, and probably fewer than that who are actively practicing, versus about 50 million people who are over 65. Now, not everyone over 65 needs a geriatrician, but we say that in part because there's so few of us anyway. We tend to focus on the frailest, the most vulnerable, the oldest, who most need us. But I think everyone, and even if you're not 65 yet, I think everyone as we're aging can benefit from learning a little bit about how geriatricians think and thinking of their own medical care in that way. So treat people, not just diseases. It's always a means to an end, and the end is about the person. And individualized care for big picture goals. This is how a geriatrician thinks. So with that framework in mind, first we'll talk about geriatric syndromes, which in many ways are at the core of the practice of geriatrics, and are an example of how we can take that complexity and actually manage it. And then we'll do some practical tips about how to think like a geriatrician should you find yourself in the hospital. And then finally, how to talk with your doctor, how to have important conversations from a geriatrician mindset. We'll start with geriatric syndromes. Many of you have probably not heard that term, but you've probably heard of or experienced what they are. One of the most common geriatric syndromes is a fall. Why are falls so interesting? Why do people fall? Well, often, when I'm admitting someone to the hospital after a fall, you'll ask them why they fell, and they'll say something about, I was in one veteran I remember well, whose family was visiting from out of town, and they were walking on Ocean Beach and tripped over a curb, or stepped on something, or the leg gave out. That may be the most immediate reason that triggered a fall, but is that really why the person fell? Probably not, because why didn't they catch themselves after tripping on the curb? Why did they catch their foot on the curb in the first place? The fall is usually the result of a complex interaction of lots of different contributing factors spanning the entire body and things that are outside the body too. So someone might fall in part because they couldn't see the curb well because of the beginnings of macular degeneration, or they use a cane, but the cane was unsteady because of the tremor from Parkinson's disease, or they were getting out of breath because of their COPD, their emphysema. We all start to get weak in our core muscles as we age. More about that a little bit later too. Or maybe it was a jolt from the pain from their knee arthritis at that exact moment, or the peripheral neuropathy that they can't tell anymore exactly where their foot is, or medications that with the best of intentions made them a little bit lightheaded that day because they skipped breakfast, or they weren't taking enough fluids in because their schedule was different, or the environment, or the caregivers or lack of caregivers around them that day. All of these things contribute to a fall. And if you're thinking about how to prevent falls, it's not just, it's not about the curb. Getting rid of the curb wouldn't have prevented the fall, but maybe enough of these other things could. And that's how we systematically approach preventing falls, for example, trying to identify as many individual contributors in the person in front of us as we can. and then doing our best to prioritize them to figure out which ones are likely most important in that individual in their health context. And then taking out our big mallet of the comprehensive geriatric assessment and the multi-component intervention, which is just a fancy way of saying, once you have all these moles lined up and figuring out the most important ones that you think, then trying to address as many of the important ones as you can in a systematic and thorough way. So this is the scientific approach to geriatric syndromes. So geriatric syndromes are, like falls, are inherently multifactorial. They have more than one cause, always. They're multi-system. It's not just about the brain, not just about the heart, not just about the kidneys or the nervous system, but it's about all of these. They're generally age-related, and aging, and working at the Buck, the way I think about this is the biology of aging, not just the passing of years, but aging mechanisms contribute to many of these causes. And geriatric syndromes are an integrative outcome. They're the final common pathway. Many paths lead to geriatric syndromes, but geriatric syndromes are very common among people as we get older. What are some other examples besides falls? Frailty, a state of vulnerability that, for example, makes people more likely to have complications from surgery. Cognitive decline. So I think of cognitive decline as a multifactorial geriatric syndrome. We often think about Alzheimer's disease or Parkinson's disease or vascular dementia. These are disease processes that are really important contributors to the multifactorial causes of cognitive decline. For example, Alzheimer's disease very rarely exists entirely on its own, but usually there's also cerebral vascular disease in the same person, and they both contribute to the cognitive decline. Declines in mobility, delirium. We'll talk a bunch more about delirium. Chronic wounds are unfortunately a common geriatric syndrome. But the good news is that we actually rigorously know how to approach and treat and improve these. It sounds like it's impossibly complex. How can you, just throw up your hands? This is too much to understand, and how can anything possibly work? And unfortunately, that was the attitude of many doctors for many decades. But some very innovative geriatricians have figured out that you can systematically work through this complexity through a comprehensive assessment and through protocolized, detailed multi-component interventions. And then these interventions get published in places like the New England Journal of Medicine. These are two examples of now, you can tell this has been around for a couple of decades, this kind of systematic approach to prevent delirium and to prevent disability in hospitalized older adults. So this stuff works and has a strong base in evidence. The way that multi-component interventions are often implemented, how do you do this in practice? It sounds great. Through a team. So geriatricians, something else that's kind of unique about us is our natural state is one of many in a team. We do everything as teams. And in many ways, I think geriatricians have really been on the cutting edge of leading this kind of change in medical practice, where now it's considered best practice for everyone to work in teams, because clearly this is a better way of doing things. So we rarely work alone. We always work in combination with nurses. We're best friends with social workers who help to connect our patients to resources to get stuff done. Physical and occupational therapists, pharmacists, because using medications in older adults is much more complicated than in younger people. When I'm working in the hospital, I'm always working as part of this multidisciplinary team. And it's just the best way of doing things. It gets stuff done. It keeps people safe. And there's more, randomized controlled trial after randomized controlled trial showing that this is a better way of doing things. That's in the hospital, and these are all medical professionals. But I think the same is true for us individually. We should all be thinking about who is my team and how can I pull a team together to meet my needs and accomplish my goals better than I can alone, because everyone needs a team. And we'll talk a bit more about this later, especially if you're in the hospital, you need a team. But we all need a team anyway. And who might be on your team? What sort of roles do I see people helping each other with in a really useful way? Well, for example, having someone to take notes for you when you go to the doctor or when you're in the hospital, so that you can focus on interacting with the doctor, and someone else can be writing things down to remember and to reflect on later. Maybe you need a handy person to help fix things around the house, or install or help to install, a ramp here or a handhold there. Everyone needs a shoulder to lean on, someone to feel connected to, someone to talk with, to hash things out with. We know so much now about how a sense of loneliness or disconnection can be bad for your health in a very concrete way. Everyone needs someone to help out from time to time, to give you a chance to take care of yourself. Many of us wind up caring for spouses with dementia or with advanced health problems. That's not a one-person job. It can't be. Everyone needs some help. Maybe that's as simple as having someone run to the pharmacy for you. Geriatricians know that taking a medicine only starts with writing the prescription, and there's so much else that goes into whether someone can actually get that medicine. And one of them is just access to the pharmacy, and forget about trying to pay for it and things like that. And everyone needs an advocate, especially when you're in the hospital. Someone who can help you express your goals, and help with those conversations with healthcare providers to make sure that your goals are at the forefront of everyone's mind. So this is an example of roles for your team. I will try to keep an eye on the chat here, and please feel free to post questions in the chat, and then of course we'll have time for Q&A at the end. So what if you should find yourself in the hospital? How's a geriatrician think about that? Well, one thing is that the hospital is a great place if you're sick. It's often really important and life-saving. Don't hesitate if you need to be there. But the hospital is also a dangerous place. Around 80% of new disability in older adults occurs around a hospitalization. Now a lot of that is because of whatever the reason is why someone found themselves in the hospital to begin with, the heart attack or the stroke or the COVID, who knows. But some of it isn't. Some of it is because of the hospitalization itself and is preventable. And anyone who's worked in a hospital has seen enough of this to know how important this is. And this is trying to prevent this unnecessary disability and unnecessary problems, is one of the most important jobs of geriatricians in the hospital. So what's behind this? I think of two major scourges, so to speak, of older adults in the hospital. One is delirium, and the other is immobility. And we'll talk a bit about both of them. First, immobility. I suspect that most of you live pretty active lives, out of bed, walking around, doing things, taking care of what you need to take care of. That will change if you go into the hospital, unless you're unless you and everyone around you pays very close attention to it. These are data from a study of active, healthy older adults, people who are living on their own, taking care of everything they need to do, don't need any help with anything, don't have any dementia, healthy, fit older adults. When they go into a hospital, and this is a good academic medical center elsewhere in the country, this is the amount of time each day that they spend lying in bed. And this is the amount of time they spend even sitting up in a chair. And this is the vanishingly small amount of time they spend upright, standing or walking. This looks nothing like their normal life. In their normal lives, they would spend 8 hours a day, hopefully lying in bed, the rest of the time either standing or walking, and quite a bit of time standing and walking. But in a hospital, for a variety of reasons, we spend a lot of time lying in bed. And actually, if you add all this up, the average older person, and this is true of younger people too, unless you tell them otherwise, the average older person spends 83% of their time in bed in the hospital, and a third of people spend more than 90% of their time in bed. You can imagine that's not good. If you've heard the phrase "use it or lose it," that is particularly true of strength and mobility for older adults. You lose muscle strength at the rate of about 1 to 3% per day, lying in bed immobile. This comes from data from the study of healthy older adults who are, for research purposes, confined to bed, but who are healthy. Nothing's wrong with them. And it may even be worse than that in the hospital when you're sick and there's lots of inflammation or an infection and things are wrong. But 1 to 3% of strength per day adds up really fast. One way to conceptualize how bad this can be is that we all gradually lose muscle strength as we age. We can slow that with exercise, but to some extent it's inevitable. 1 day of hospital bed rest is equivalent to the strength loss of a half year to a year of aging. Every day in bed is like getting older a year. That adds up fast. And this is the number one reason why so often when people come out of the hospital, even if you fixed the pneumonia or the heart attack, they're still not well and maybe not able to walk as well, maybe not able to go up the stairs to their house, maybe not able to walk at all. We can prevent a lot of that. So that's immobility. The second is delirium. Delirium is something that you may not have heard of, but you may have experienced in a family member or a loved one or a friend when they're in the hospital. It's a sudden confusional state brought on by being sick or by being in the environment of the hospital. It happens to up to half of older adults in the hospital. It happens more often the sicker you are. So if you're in the intensive care unit, almost everyone is delirious. If you have Alzheimer's disease or dementia, it doesn't take that much to make you delirious, maybe even just a bladder infection. Delirium is a really serious problem, and it's really distressing to the people who experience it and to those around them. So it involves disorientation. You don't know what's going on. You don't know where you are or why you're there. The people coming to stab you with needles, you don't understand what's happening. Often hallucinations, these can run the gamut from kind of simple things like seeing curtains move when there's no one there, or seeing faces in the windows, to if you read the recollections of ICU survivors about their delirium experiences, some of this can be really just Lovecraftian horror movies of swimming in seas of blood and having their limbs hacked off and things like that. And these hallucinations from delirium are thought to be a major part of why ICU survivors have PTSD, post-traumatic stress disorder, and other symptoms of psychosis. Like it's often paranoia is very common in delirium, and you'll hear people thinking that telling you that their family is out to get them, is stealing from them, is trying to kill them. And sometimes that may be true, but often it's the psychosis of delirium. So this sounds terrible. The only good news is that delirium is reversible. If you're careful and you fix the underlying problem that triggered it, it can go away, and sometimes fairly quickly, but it can also last for days to months. And over the long term, just having had delirium makes you 5 to 10 times more likely to be diagnosed with dementia in the future. So delirium is a really serious problem. It's a geriatric syndrome, and we've studied ways to implement systematic multi-component interventions, which can be really helpful, can prevent over a third of cases of delirium in the hospital. And this is often simple things like make sure that the shades are up, natural light is coming in during the day. Write your name and the date on the whiteboard. Get out of bed as much as possible. Get out of bed for meals, go walking, make sure that people have glasses and hearing aids. This all sounds really simple, but you put it into a systematic, protocolized, hospital-wide intervention, and it can really help. But those words are doing a lot of work. Systematic, protocolized, hospital-wide. This is not easy to implement, and many hospitals don't do this. So what can you do to prevent these scourges of delirium and immobility, and make sure that you can dance your way out of the hospital instead of being wheeled out to a rehab center? And a lot, actually. So first, these are difficult things to implement in a hospital. They shouldn't be, but they are. So look for hospitals and medical systems that have these services available. So for example, If you're getting ready for a big surgery, or getting ready to start your chemotherapy or something, look for specialty clinics that specialize in exactly that, getting older adults ready for the big health stress. Often this is called prehabilitation now. You guys have heard of rehabilitation. This is doing it beforehand, prehabilitation. For example, there's a surgical wellness clinic at UCSF, which has a beautiful multidisciplinary team, like I showed earlier, to do exactly this, to help older adults get in the best shape before they get into the hospital. Once you're in the hospital, or if you have a choice of hospitals, hopefully, look for programs like this. Look for hospitals that have a geriatric program. Look for acute care of elders units, or a hospital elder life program. They go by different names, but some sort of hospital-wide program that focuses on keeping older adults fit and healthy while they're in the hospital. This has become actually a major national initiative among health systems. The John Hartford Foundation is spearheading this, the concept of the age-friendly health system. The UCSF system is embracing this wholeheartedly. It's really been wonderful to see over the last 5 years. Can't say it was always the case before that, but I'm really gratified that UCSF has really jumped into this with both feet. Many other health systems around the country have too, but of course not all. But look for or ask about age-friendly health system. The simplest way to conceptualize this is it involves implementing the 4 M's in every part of the healthcare system. The 4 M's are talking about what matters and putting that in the front, goals, as we talked about, focusing on medications and medication safety for older adults, mentation, including preventing delirium, and managing dementia and depression, and ensuring mobility. The simplest things of making sure that people are moving out of bed as active as possible, because that helps everything else. So what matters: medication, mentation, and mobility, the 4 M's, as a really nice, quick, handy summary of the principles of an age-friendly health system. That's about the system, but there's still a lot that you can do personally and that your team can do with you when you're in the hospital. Number one and most important is get out of bed, mobilize. If there's folks, discouraging you from doing that, find out, you and your advocate, find out why and try to address them. Stay out of bed, walk as much as you can, stay active during the day. I can't say that enough. Being as active as possible in the hospital is so, so important. I would put it on equal footing with whatever the treatment is that you went in there to get. It's right up there, co-equal with treating the pneumonia or the COVID. You can try to manage delirium risks yourself too. So for example, it's okay to ask for a quiet, dark environment at night. It's okay to ask them to raise the shades during the day, or to help your advocate do that with you. It's okay to ask for earplugs and an eye shade at night. People, when we work in the hospital, you work 24 hours a day, and without meaning to be a bad person, people just forget that how important it is that your work environment is someone else's time to sleep and recover, and that is actually really important in a science-based, evidence-based way. So it's okay to advocate yourself for things like that. Be careful with medications. Often hospitals are protocolized, and people get this or get that. Often those are good, but it depends on whether a geriatrician and a geriatric pharmacist help to design those protocols. Always double check the medications, especially double check that you're getting the medications that you usually take at home, if appropriate. Mistakes in translating medical lists from home to hospital are extremely common. Always good to double check. And ask about any new medications, especially ask about any medications that are going to affect your thinking. Sedatives, pain medicines. Pain medicines are often necessary, especially if it's important to treat your pain so that you can get up and mobilize and get out of bed and walk. Sedatives, be really careful with. Sleeping pills don't work. Sleeping pills are very likely to make people confused and delirious. There are other ways to try to get a better night's sleep in the hospital, like trying to manage the environment and staying active during the day. But be very careful with medications. And it's okay to ask people to slow down, to ask what's going on. And your advocate in the hospital can help with this too. You should always understand what's happening. If someone is delirious, or someone has Alzheimer's disease, this is even more important because you have to take your time with them and explain to them what's going on and reassure them so that you don't wind up causing more problems. You can imagine if your brain works kind of slow and is a little bit slow to interpret new environments, and suddenly you're in this place where you're half naked in a bed with a strap with things wrapped around your legs to try to prevent blood clots, and someone sticking a needle into your arm. This is a very confusing state, and we know that in Alzheimer's disease, processing time is slow. We need to take our time. People can understand, but we need to take our time with it. So that's one reason why having an advocate with you in the hospital can be so important, to help remind people to slow down and take their time. I've talked a bunch about how useful it can be to have a family member and advocate with you in the hospital, even in COVID times. That is really important. And most hospitals have made, even though they're tightening down on visitor restrictions, most hospitals, and any good hospital, frankly, has protocols to permit visitors for older adults, because having this advocacy is so important to good outcomes for older adults. COVID cannot shut that down. If someone has COVID, that's a little bit more complicated. We can talk about that. But just because there are visitor restrictions in the hospital doesn't mean that you have to be alone. And finally, design of a hospital matters a lot. The little things. Why do we spend all day in bed when we go into the hospital? And it's part because the design of hospitals often makes it hard to get out of bed and also encourages you to stay in bed. So for example, to encourage mobility, at the very least, we should get up to go to the bathroom, but that requires that the room be big enough and have clear pathways that can accommodate a walker, ideally, to get to the bathroom and to get out the door into the hallway. And not every hospital has that. If you're designing a hospital to help older adults be as healthy as possible, you pay attention to all these things. Every room should have a window. There should be destinations to go to, a place to walk. Maybe that's a common room or a place with a nice view. At San Francisco General, the geriatric unit is on the same floor as the outdoor gardens, which is wonderful. It's a nice place to go for a walk. And the appropriate lighting, colors, to accommodate people who may not have the best vision. Something as simple as door handles. Having a door handle that, if you're using a cane or a walker, you turn instead of push, so that you're not putting your weight onto it, so you don't fall forward trying to open the door. And in a properly geriatricized hospital environment, these things are taken into account. This is particularly important. It's hard to retrofit old hospitals. It's especially important when new hospitals are being built. It was so wonderful that San Francisco General actually had a geriatrician consulting on the design of their older adult floor, and it's an entire floor optimized in this way. I hope that when UCSF builds their new hospital, for example, that there'll be a similar focus on design elements that are really necessary for an age-friendly health system. So the last section here is about important conversations. Sorry, I'm just trying to peek at the chat here. Okay. So important conversations, how to talk to your doctor like a geriatrician would. So thinking back to the idea of focusing on goals and big pictures, and advocating for yourself. Keep in mind, it is your health. So when you visit a doctor, the doctor will have an agenda, the things that they think they should talk with you about and maybe do. You should have an agenda too. You should be thinking about what matters the most to me. What are my goals for my healthcare? If you're talking about starting something, a new medicine, a surgery, doing something, what's the goal of it? And how does that align with your goals? Even if you've been doing something for a long time, that doesn't necessarily mean that you should do it forever. So even if you've been taking a medicine for 20 years, it's always good to ask, should you still be doing it from time to time? Because your body changes, your needs change, your goals change. And you should always periodically think about, what should we be doing differently? Whenever you're thinking about something new, always think about, how does it affect everything else that I'm doing? And that can be in a very narrow way, like, how does this medicine interact with my other medicines? A lot of you are probably comfortable asking about that, but also in a bigger picture way. Like, for example, if you need to manage a new serious problem, but a big part of your health is about a particular kind of activity that you really enjoy and that keeps you fit and active, how will the new medical approaches, which are maybe trying to help you live longer, but how is that going to interact with the other things you're doing that are important to you? And maybe there's a need to optimize or tweak things to make sure that it helps you as a whole person. And it's always important to ask, is this the right care for me? Again, meaning that it's really easy to think of all the things that we can do, all the medicines that we could prescribe, all the tests we could do. But the question is, what's the right thing to do for you right now? So the hard part is not guessing what might help. We're pretty good at that. The hard part is figuring out what's most important, what's likely to be most impactful, and what's going to most help a person achieve their most important goals. So one example of this, specifically talking about medications. Medications save lives. Lowering blood pressure with medicines, we're learning more and more about just how helpful that is in preventing strokes, in preventing heart attacks, in literally preventing people from dying. Medicines save lives. But more is not always better. Whether you're talking about the total number of medicines you take or the number of medicines you take for a particular condition, like heart disease or diabetes. I think of this kind of curve of diminishing benefits. So the first medicine is really important and often really helpful. The second one, still helpful, but probably a little bit less so. The third, fourth, fifth, sixth, seventh, you're probably reaching a point of diminishing returns. Each medication adds a little bit less in benefit. But each medication adds increasingly more in risk because the number of interactions increases exponentially, the number of potential problems increases. And these include, causing falls, contributing to cognitive decline, precipitating delirium. Some medicines are particularly prone to leading to hospitalizations that are potentially avoidable. Interactions, side effects, the more medicines you have to take, the easier it is to not do it right. I have a hard time just taking medicine 3 times a day. Forget about if I were taking 12. So together with this diminishing benefit, as you add more and more, you get increasing risk. So the trick of a geriatrician, of all of us, is to stay in the Goldilocks zone here, to be getting the most benefit we can with the least risk. And often that means prioritizing, really trying to be thoughtful about what's most important and how are individual medications interacting with each other and interacting with your other health problems, which are doing more harm than good, which are really important. And this changes as we get older. Our bodies change in ways that we all feel, but also in ways that affect medications specifically. So as we get older, often we're slower to clear medicines from our body so they can build up. This is because our kidney function declines with age, and to some extent our liver function declines with age. And this is how your body gets rid of drugs and medications. So sometimes doses need to be lower. You need to start low and go slow. That's also because as our body composition changes, the doses will change. So we tend to lose muscle and gain fat as we get older. But some drugs are absorbed into fat. And so they may require different doses in younger people than older people. Interactions are much more common just because as we get older, we tend to have more reasons to take medicines. And so we tend to take more and more. Polypharmacy, which is a term for just taking a lot of medicines, becomes really common. So interactions are more common and have to be paid close attention to. And side effects are more likely to be significant. I think it's not so much that older adults are more likely to get side effects, but that when they do, they're more likely to cause problems because we have less resilience. Just like how all of these different components can contribute to a fall, in the same reason or in the same idea, many of the different ways in which our bodies change as we age can make us more vulnerable to serious problems from side effects. So a simple example, dizziness from low blood pressure, pretty common, something you generally want to avoid, at least in terms of not wanting to cause that with medicines. So how is this different in older people versus younger? So, for example, our arteries are stiffer when we're older. And so changes in blood pressure are kind of communicated more quickly. Our arteries can't squeeze or relax as well to compensate. Our hearts, usually if our blood pressure starts to drop, our heart will beat faster and will squeeze a little bit harder. But that happens more slowly as we get older and our maximum heart rate drops. Our kidneys have a harder time concentrating urine, which makes us prone to dehydration. If we get dizzy and we stumble, we'll be less likely to recover ourselves because we are a little bit weaker. We've lost some muscle mass, and especially our core muscle strength gets lower as we get older. And our veins have a harder time keeping blood from pooling in our legs. And all these things together, not one of these things is going to make you have a fall from low blood pressure, but all of them together make you a little bit more prone to, if a medicine drops your blood pressure a bit too much, if you're a young person, you'll feel a bit lightheaded, but be okay. But if you're an older person, it may cause a more serious problem. So putting all of this together into a framework, how to make decisions about your health with your doctor and your other medical professionals. We think about this interaction of first, your priorities, your goals, what do you want to accomplish with your medical care? Putting things into the context of your medical history. What other medical problems do you have? How will this new decision interact with the problems you already have? And how do those problems affect this new decision? So for example, if you're thinking about new medicine, you have kidney problems. Will your kidney problems affect this new medicine? Is there a different choice? Does it affect the dose? Will it harm the kidneys? And putting it into context of your other medicines. How will this new thing interact with, for example, your warfarin? How will this work with the other medicine that you take for that? Is this overlapping, or is it meant that they'll both help each other? But always coming back to the priorities. How do you weigh the expected benefit versus the possible risks? How would common side effects affect you if they happen? If you got what might be a mild side effect in someone else, would it not be a mild side effect for you because of the rest of the context of your health? And is this the most important medicine? Is it the most important thing you need to do to stay healthy? Or is it like the 10th most important, and maybe something that you do on a trial basis, or maybe you think about whether it's worth it, or whether there's other ways to approach that problem. But setting priorities together with your doctor. So this is how a geriatrician thinks, focusing on goals, focusing on the whole person, the big picture, and embracing that complexity, and needing to always think about how everything interacts with everything else, and how to be very thoughtful and strategic about how to meet your priorities and how to do more harm than good. So that was the end of the slides, and then I'm happy to answer the questions in chat and take other questions too.
John, thank you for a wonderful presentation. I think there were a couple chat questions in there. I'd be glad to get it over to you, or I think you can see the chats. And then after you address the chats, perhaps if you have a question, could you put your name in the chat box so we can call on you? That would be very, very helpful.
So Dana asks, is there a difference between a gerontologist and a geriatrician? It actually depends what country you're in. In the US, geriatricians are the clinicians, and gerontologists is generally used for scientists who study aging in any sort of way. That includes people at the Buck who do basic science, but also people who do clinical research or other things, or social science. In other countries like the UK, though, gerontologist is the name of the clinician. So I'm not sure why that's quite so confusing. Sandra asks about Dr. Bredeson's Alzheimer's protocol. I'll just say that the concept is very interesting. You were probably thinking it fits into this idea of comprehensive assessment and systematic multi-component interventions. I'm not aware that it's been rigorously tested, and that is actually a big difference. It is possible to do clinical trials to rigorously test what works and what doesn't, and I think it would be wonderful if it were.
I see that there is a question from Terry Parker. If a family member is not available, what types of professionals could be hired for the role? And I believe that's for advocate.
Yeah, great question. So of course, a lot of this often falls on family members. And that can be very challenging, especially if family members are on the other side of the country, for example. But there are professionals who do actually specialize in this sort of advocacy and care management. Look for geriatric care managers or care coordinators. This is a class of professionals, sometimes with nursing backgrounds or social work backgrounds, sometimes layperson backgrounds, who have training and expertise in exactly this sort of thing, exactly interacting with healthcare teams, interacting with long-term care facilities, for example, and helping to do that kind of advocacy. There are a number of them in Marin County. I've worked with some of them when patients that they help are admitted to the VA or UCSF, and it can be really, really helpful. So geriatric care managers.
And Stephen, you have a comment or a question? Can we get him unmuted for Stephen? I think he's talking, but Stephen, you're muted if you hear me.
Hold on.
There you go. Oops, muted again. There you go.
Now?
Yes.
Okay. Two things. Years ago, I've been here 11 years at Oakmont, and maybe 8 years ago, I was approaching the fitness center, and out of the building of the CAC came a group of people. They happened to be Japanese, I discovered. One man in front holding a pole. So they about 20 people walked out following him. Mm-hmm. I asked one of them, what's going on? And John, do you know what I'm going to say? You're smiling. It was a group of, I guess, fellows from Japan, medical fellows who were studying to be geriatricians. And they knew of Oakmont and how healthy people here were. And so they had flown here and were visiting Oakmont. And they had just come out of the fitness center.
That's fantastic.
The second thing was about falls. I recently was in the Oakmont physical therapy for a inflammation in my gluteus muscle. But one of the things she did is she said, I want you to walk. And she watched me walk back and forth, and I was walking completely wrong. And she said, you don't lift your toe up and step down on your heel. You put your foot out. And that's why I've had years of falling. I wasn't walking properly. And I'm practicing that as I walk now. She taught me a new way to walk. So I thought that was pretty helpful.
That's a great example of a multidisciplinary team. And physical and occupational therapists are also my best friends. They're incredibly valuable. If you find a good one, stick with them. And that's a good one.
A new one here at Oakmont, Natalia. She's terrific.
Fantastic.
And then we have a question on chat. John, if you could address Elaine Rivas's question. I don't know if you can see that.
So prior to an event or incident that causes hospitalization, what can we do well to prepare for that possibility? Like lining up your personal team. Well, a few things. I think one is, the best way to be fit before a major health problem is to be fit. And, of course, just like Stephen was saying, you want this is probably something that you want to do anyway, but, maybe that's a good excuse to be a little more active, to start an exercise program or to rearrange your life a bit to be a more active life. But it's never too early to prepare. If you're a little bit closer, you can do that more intentionally, in the sense of, for example, a major part of most prehabilitation programs is working specifically with a physical therapist on a monitored graduated exercise program to try to quickly get into better shape, in order to be more fit for your health stress. Doing regular maintenance with your doctor on your medical problems and medical lists are really important. And again, you can do this more intensively close to when something is happening, but it's a good habit to be in anyway. And what I mean by that is, on the one hand, checking in on what's still needed and what's not. So these medicines you've been on for 30 years, do you still need them? Paring down medicines that may be doing more harm than good. Often we think about sleeping pills, for example, or there's a few other classes of medicines that tend to just accumulate on people's medication lists, sometimes without good reason. So parsing through, doing kind of spring cleaning on your medications once in a while, but also keeping up with health maintenance, keeping up with cardiovascular risk management, keeping up with blood pressure checks, keeping up with cancer screenings appropriate for your age and function, keeping up with vaccinations. Never more important than in the time of a global pandemic. I suspect all of you are boosted. That's fantastic. Keep that up. The best way to be in good shape when you face a stress is to always be in the best shape you can be. But it's never too late. These are the core components of a prehabilitation clinic, incidentally. It's generally some form of physical therapy focused on function and fitness, talking through carefully with a doctor and a pharmacist about your medications. And then another part of that is, as you're saying, get your team in order who might help advocate for you. And, friends often do this for each other. And, talking about that in advance is always helpful. But also talk with whoever's would be your advocate, whoever would help you make decisions if you became delirious, or talk with them about your goals and needs. Talk with them about what you would want or not want if you were seriously ill in the hospital, if the worst happened or if the best happened. We call that advanced care planning. And part of that is designating formally and legally a person who can speak for you if you're unable to speak for yourself, but also making sure that person is able to speak for you because they know what you want. They know what your goals are. It's never too early to do advanced care planning. And I have a particular website to suggest, which is Prepare for Your Care, developed by a geriatrician at UCSF, which makes the advanced care planning process very simple, and is available in a bunch of languages and to people all over the country.
George McKinney, you have a question?
Yeah, one of the problems with multiple medications tends to be that they have been prescribed by multiple doctors.
Yes.
Okay, and each doctor has a reason why he or she thinks that that's the perfect thing for you.
Mm-hmm.
How do you get around that?
In the ideal world, you'll have a primary doctor, and maybe this is a geriatrician, or maybe it's a primary care doctor who's able to spend the time with you to kind of filter all of that and take the input from the subspecialists, put it into that big picture, and decide with you what's right for you as a whole person. In practice, that's often hard because primary care doctors are very rushed, don't have the time to do that, and often will just, hey, the cardiologist said this, so we'll do this. And therefore, it often falls on you to integrate that input from people with extremely good expertise, but often a narrow focus, and how that affects everything else that's going on with you. So ultimately, it sometimes means that you need to kind of ask the questions of the subspecialists and help to figure out how things can all fit together.
And I think Phil Herzog has a chat question for you.
And I will say that geriatricians I completely agree with you. And often this is a source of problems. And so geriatricians often feel strongly. And so, for example, if you're in our VA geriatric primary care clinic, we want to do all the prescribing ourselves. Not because we know more than anyone else. We don't. We very much appreciate input from subspecialists, but we know how easy it is to cause problems when you have 6 different doctors not talking to each other and writing prescriptions. It's a recipe for disaster. It's so much more helpful to take that input and centralize it. And if you can figure out how to find that doctor who will be the central coordinator, just like a good physical therapist, if you can find that person, stick with them. A couple questions about finding geriatricians. But maybe first, Phil asks about what if they want to change your medications when you're in the hospital? Well, sometimes that's for good reasons, sometimes not. The first thing I would ask is to make sure that they know what medications you've been on, because often that's a common source of misunderstandings and errors. So a lot of medication changes are not intentional. Sometimes it's an artifact of, what does a hospital use, what's on formulary. Maybe they switched your blood pressure medicine when you got to the hospital because a similar one is on formulary there, and then they forget to switch it back when you leave. These are what lead to medication errors around hospitalizations, but sometimes it's for good reason. And so when there are changes, ask why. And in general, as a hospitalist, I try to take a light touch. I make the changes that are essential to fix the reason why someone's in the hospital. But I generally otherwise defer to someone's other outpatient doctors because they know you a lot better. And often there's good reasons why you're on the medications you're on. And in general, having a light touch is better, less likely to cause problems than wholesale changing someone's medication list in the hospital. We know that can cause problems.
And George, you have another question?
Yeah, one of the things that always seems confusing when you get into a problem is the pain scale, okay, which can mean one thing to one person, one thing to another. What is the most productive way as a senior for me to respond in a pain scale question?
Great question. And then we've been treating pain as a vital sign for a number of years now, which I think is appropriate. It is totally subjective. And I think providers realize that it's, each person has their own sense of, answer it. I would answer it, as you think is appropriate for you. But I guess keeping in mind that, pain is, ideally, no one would have to live with pain. Sometimes we do. Sometimes the treatments for pain can be counterproductive, but it's most important to treat pain when it's getting in the way of other things. If it's, certainly if it's to the point of debilitating you, if you need to treat pain enough so that you can walk, so you can run, so you can play tennis, so you can do the things you need to do, and you need to treat the pain in those contexts, focused on those goals. So I guess, take the pain scale with a grain of salt. It's not meant to be the sort of thing that, oh, your pain is a 7, you need to take some morphine. Hopefully not. It's not the way that they're using it. But certainly always bring up pain when it's new or when it's causing problems with your day-to-day, because that often is something that you really want to address early and effectively so that you can keep doing the things that you're doing. To me, that functional outlook on pain is what's important.
Okay, and we have a question from Stephen about how to get a geriatrician on your team when you're in the hospital.
So there's a couple of different ways this can be done at different hospitals. Some hospitals have geriatric medicine consults, a consultation service where a geriatrician can come and see you and help out your other doctors. You can ask if that's available. Sometimes that's implemented in an automatic way. So UCSF has an acute care of elders unit that I believe sees automatically everyone who's on a certain floor of the hospital that's designated as that unit. So you can ask if you're on that floor of the hospital, if you're on a floor where a geriatrician will see you. And you can also ask to be moved to that floor of the hospital if possible. But even in those automatic consult services, you can still ask if usually they'll do consultations as needed too. You can always ask your team if a geriatrician is available.
John, I have a question, and that is, I've noticed that many independent doctors are now aligning with either Providence or Sutter. And so you may have two different providers now, and they don't communicate, or they don't have dashboards that communicate. Do you have any information or any ideas on how to bring that in line where you can manage two different providers, two different health providers?
Yeah. There's not a good answer to this, or at least not an answer that I wish things were easier. The reality is that often providers within a system will interact pretty well with each other. And that's been getting easier. It's one of the things that EMR and email and whatnot are actually good for. So that's a good thing. If you're in Kaiser or if you're in UCSF, like, people do talk to each other. Across systems is still really hard. It's just the data sharing is better than it used to be, but it's not smooth. It's hard to figure out how to communicate with people. And the only way to guarantee it happens is to do it yourself. And this can be another role for an advocate. And what I mean by that is you may wind up having to be the repository of information that you can then share. So get copies of your notes, get copies of your lab tests, get copies of your discharge summaries. Again, this shouldn't be necessary, but the most incredible things I've seen are patients coming in with little binders of their health history, and their organized medication list, their most recent notes from their providers, and it's all right there, and that's amazing. You shouldn't have to do that, but it's actually really, really helpful. And just facilitating that contact. Make sure if you have a few doctors that you like to see, and they happen to be in different systems, make sure they all have each other's contact information. Make sure they all have each other's emails. You could even ask if they'd be comfortable sharing their cell phones with each other. Often doctors are a little bit less squeamish about that doctor to doctor than patient to doctor. But see if you can make a contact between them to facilitate informal communication, because that winds up being the most useful kind.
I think, does anybody have any more questions? If you'd like to either raise your hands, we can see you visually, or if you'd like to get on chat. Stephen, you looks like you have a question. If you'd like to unmute yourself, please. There you go.
This is a very personal one. My primary care doc is up here and has been for the last 11 years since we moved up here. Mm-hmm. But I get almost all my real serious medical care, all of it at UCSF. Is this a wise thing, or should I have a PCP down at UC? I don't know, because if something really serious happens, he's up here and I'm down there.
Well, I'll generalize that. I think, UCSF is a great place to get sophisticated healthcare. And I think that's, large tertiary quaternary care centers, that's often where you want the most complex care. It's really important to have a primary care doctor who's accessible, though. So in a situation like you're describing, I think it's actually a good thing to have a primary care doctor closer to you, and probably more accessible, both physically and hopefully in terms of communication too. The trick, though, is just making sure that they have the information they need. So that's where maybe that binder comes into play. UCSF is expanding its interactions with other systems, so it's possible that maybe that person can get onto Apex and can look at your UCSF chart. If you can help them do that, do so. And otherwise, just make sure that you're the conduit, that you have the notes from the specialty providers, that they know what's going on, and you probably need to just update your PCP periodically for what else is going on in your health, and make sure that they stay up to date. But I think that having a good PCP who you trust, who listens to you, who you can talk things out with, and who is accessible to you is so invaluable. I would hang on to that.
And what is Apex?
APEX, oh, sorry, APEX is the electronic health record for UCSF. There is some interconnection between APEX at different institutions, so it's possible that depending on this person's affiliations, they might be able to see parts of your electronic health record directly. May not know that they can, and that's where you can come in.
Okay, and our last question today, Peggy.
Hi, great talk. Thank you very much. Kaiser is so huge. I've been with them for years. Never thought about a geriatrician. Does Kaiser here in Sonoma County have such a thing? Do you know?
Yeah, and a couple other people asked, where can we find geriatricians? There's not very many of us, as I said. Kaiser does have a few. I know of a former UCSF fellow, colleague, who now works at Kaiser San Rafael. I believe there's a couple in Sonoma, but I'm not entirely sure about that. Geriatricians tend to be found at academic centers. It's the whole, like, there's so few of us, you know, we tend to gravitate into, if we can turn the whole health system into an age-friendly health system, we can have more of an impact than one-on-one. So UCSF has a lot of geriatricians. They do some work in Marin, none in Sonoma. But again, that's still mostly centralized in San Francisco. And then surprisingly, Marin, as far as I know, doesn't have a ton of other geriatricians. And I'm not entirely sure why that is. You can certainly, you know, your insurance company, but also your health system will have websites where you can search for doctors, look for people with geriatric medicine credentials or geriatricians, and ask around. Ask your doctor, and also I'm happy to try to make suggestions too. We keep a little bit of a database because we get this question so often in our division at UCSF. You know, does anyone know of a geriatrician in the South Bay or in Sonoma or in Marin? And often it's, there's not too many, but we can try.
Okay, thank you.
And John, we want to thank you for coming and talking to us. We know we've been having quite a few speakers over the years from Buck Institute, always informative, incredibly good information. So we want to thank you, Sunday Symposium, and all our followers for coming and representing the Buck Institute. I want to remind everybody that's here today that we will have a wonderful talk on Sunday by Suleiman Clark for the Friends of Freedom. We hope to see all of you, and we hope you all stay well and keep posted on to our website, or you might be getting emails on when we're going to go back live and if we're just on Zoom. Thank you very much, and thank everybody. Have a wonderful, wonderful day.